So we can start. Good evening, good afternoon, good morning, whatever. So welcome to this joint EUBreast and ESSO webinar. My name is Oreste Gentilini from Milano, Italy. I'm also vice chairman of EUBreast, and today we're going to discuss about the controversies which were raised in the recent St. Gallen conference about local regional treatment. We hope and we expect this to be as much interactive as possible, and in fact we are going to ask for your opinion. Obviously, you're asked, you're encouraged to ask questions, so feel free to use the question and answer option. So we have Thorsten Kuhn from Esslingen, Germany, who is chairman of EUBreast, and Thorsten is going to make some closing remarks at the end, and Thorsten and myself will act as, let's say, provokers by making some comments or even asking some nasty questions during the event. We have two outstanding guests today, Terry King from Boston, USA, and Nicro Meatini from Florence, Italy. But I will leave our host to properly introduce them. Our host today is Isabel Rubio, President-elect of the European Society of Surgical Oncology, President of EUSOMA, member of the Executive Board of EUBreast, and then I'll stop because otherwise it's going to take too long. So Isabel, the virtual stage is all yours. Isabel, please.
So good evening or good afternoon, everybody. And as Oreste said, thank you, Oreste, and thank you, everybody, for attending this webinar. I'm just going to give you a little bit of how it's going to be and then present our speakers. So we are going to have 10 questions that we will put up on the screen so you can vote from your house. And then we will see the results, and we will compare the results with the results that we had on the consensus at St. Gallen. And then we will have a little bit of discussions regarding the questions. So let me first introduce you our speakers. Thank you, Dr. King and Dr. Meatini, for being here, sharing with us this panel today. Dr. King is the chief of the Division of Breast Surgery at the Brigham and Women's Hospital, and also she's professor of surgery at Harvard Medical School. And Dr. Meatini is a radiation oncologist at the Florence University Hospital, and also associate professor of the university there. So welcome both of you, Thorsten, Oreste, and I think that we may start because in the sake of time, we have 10 questions. So we'll just put up the questions, I will read it, and we will vote and go from there, okay? So can we have the first question, please? So the first question says, there are 3 questions like in one, so you will vote. The first one is, which patients with estrogen receptor positive DCIS and adequate resection margins may omit radiation therapy after breast conservative surgery if the patient is older than 70 years old? Yes or no? The second one is, which patients with same patients with estrogen receptor positive DCIS and adequate resection margins may omit radiation therapy after breast conservative surgery if the patient has a tumor with low risk biological or genomic profile? And the third question, same thing, if they can omit radiation therapy after breast conservative surgery if the tumor is low grade. So you can vote now, yes or no, to the 3 of them, and you have 30 seconds to vote.
You have 20 more seconds. Ten more seconds. We are ready to go.
Okay, so let's see. So for the first question, in patients older than 70 years old, 63% vote yes, you can omit radiation therapy. Maybe we can go, let's go one by one, so it will be easier. So just to compare with the consensus at St. Gallen, in there, 58% vote yes. So, half and half. Dr. Meatini, any comments on this?
Yeah, I think that's a very nice question, since the main question is there's a place for a de-escalation of treatment in DCIS, and as you can see, there's very debated. Always a very debated question, since you know that the pivotal trials say basically that postoperative radiation therapy after a conserving surgery usually halves local relapse risk in most of patients irrespective of age. So it's something that you have to take in account, but age, it's not the only aspect that you have to consider when omitting or not radiation therapy.
Yeah, so Dr. King, it seems that people are more prone to omit surgery in low risk tumors than in age. Is that right?
To omit surgery or omit radiation?
I omit radiation therapy, sorry. I'm prone
yeah.
to
I think, there's a lot of discussion and work going on as to who really needs radiation. As was mentioned, all the randomized trials showed that, collectively everyone benefits, and even low risk disease the risk of recurrence can be reduced with radiation. But I think it's nice that we are considering these molecular profiling and things to move towards more individualized approaches for DCIS, since we know that survival outcomes are excellent regardless of whether we use radiation or not.
Yeah, so it seems that we are more or less on consensus with St. Gallen and with the rest of the panelists. So let's move to the second question.
Well, Isabel, can I just make a small comment? Just a small comment on the third question, because I just wanted to quote some data when I was back at the European Institute of Oncology, because in that institution at that time, we were not giving radiation therapy to patients with well-differentiated DCIS. That was the policy of the institution in the early 2000. And actually, in the population, in the subset of patients below the age of 40, the recurrence rate was 40%. So if we are going to omit radiation therapy, or if we are going to rely on surgery alone, breast-conserving surgery alone in that population of patients, even with a well-differentiated DCIS, the outcome is not going to be perfect.
If I further comment, Oreste, I perfectly agree with you, because we know that basically radiation omission nowadays currently could be considered only in a very, very low risk patients. So basically, we know that hypofractionation could be an option. Radiation therapy, tumor bed boost could be omitted in most of cases, mostly if final surgical margins are adequate, as in this case. And then you have to consider also if the patient is receiving or not endocrine therapy. That is another important point in terms of the escalation or not of treatment. So I perfectly agree with you.
Yeah, well, the questions are like that. So, if you start considering age and the other factors, but, yeah, completely agree. Okay, let's move to the second question. So the second question is targeted axillary dissection an option in clinically positive patients with CLIP-marked initially involved nodes who convert to clinically negative before surgery? Yes or no? And the second question is targeted axillary dissection an option exclusively in patients with favorable biological tumor subtype? So please vote.
You have 20 more seconds to vote.
10 more seconds. We are ready to go.
Okay. So to the first question, the answer, the majority, 86% say yes. And for the second questions, the majority says no. So Dr. King, can you comment on this?
Yes, thank you. So we certainly know that there have been multiple trials demonstrating the feasibility of sentinel lymph node mapping and biopsy in those clinical N1 patients that experience a good response to neoadjuvant chemotherapy. And so the targeted axillary dissection approach is a refinement of that technique, which allows us to further decrease the risk of a false negative when performing sentinel node in this setting. So I think that it has been demonstrated to be a feasible option, and we are now starting to get some outcomes data from patients that have been managed, again, with sentinel lymph node biopsy with different techniques to minimize the false negative rate, not just the TAD procedure, and seeing that those outcomes look, relatively favorable for these women in the short term. We're not seeing high rates of axillary failure. So I think that's all very, very promising as we move forward.
Yeah, and I can say that the answers completely agree with the answers at St. Gallen, where the first question, the yes was 90% and the second one was 86%. Dr. Kuhn, any comments? Want to make any comments?
I absolutely agree with the voting from St. Gallen, but also from the attendees here. But I think we have to keep in mind that so far I think it's very clear that target axillary resection is an option. I think there's no doubt about that. But so far we only compare false negative rates, and we do not have any comparison regarding long-term outcome, especially with regard to disease-free survival, but also life quality. And we have no comparison between sentinel lymph node biopsy and target axillary resection. So we don't know if costs or morbidity, how many lymph nodes I take out. And that's the reason why we initiated the EXANA registry in the EUBreast study group, which is just a prospective registry. And we include every patient, every stage of procedure according to the national guidelines. And then we can compare morbidity and outcome of axillary resection, sentinel lymph node biopsy, target lymph node biopsy alone, which is an option in the Netherlands, or target axillary resection.
Okay, so good. Let's move to the next questions. So as you can see, we have in all 3 questions in one, but that will make things more nicer here. So the next question is axillary dissection always indicated following neoadjuvant therapy when there is residual cancer in the sentinel lymph nodes? And the answers, depending on the size of the metastasis in the sentinel node. The first one is if we have a macro metastasis in the sentinel lymph node. The second one is if we have a micro metastasis in the sentinel lymph node. And the third one, the answer is if there is at least 1 positive sentinel node out of 3 sentinel lymph nodes evaluated. So vote now to know if axillary dissection is always indicated in these 3 different settings.
You have 20 more seconds to answer. Ten more seconds. We are ready to go.
Okay, so for the first question, if you have a macrometastasis in the sentinel node, the majority have voted to do an axillary lymph node dissection. When it comes to micrometastasis, then we have 50 and 50 who said yes and 50 who says no. And if we take into account the number of sentinel nodes and there is only 1 positive out of 3, the majority also said to do an axillary lymph node dissection. As I can tell you from the results of St. Gallen, to the macrometastasis, the first question, it's more or less the same, 25% versus 75% versus 25%. The second question, 50-50, 50-60, a little bit more to the no on St. Gallen. And to the third question, more or less the same. So what do we do with the axilla when we have a positive sentinel node, Dr. King?
So I absolutely am still in favor of an axillary lymph node dissection in the setting of a positive node after preoperative therapy, particularly in patients that start out with clinical N1 disease, unless that patient is enrolled on a clinical trial, such as the Alliance trial, which is randomizing them into axillary radiotherapy as an alternative to lymph node dissection. But until we have the results from that trial, I think that lymph node dissection should be considered the standard approach. And I think that this hypothesis that maybe a micromet is not as important after neoadjuvant chemotherapy than a macromet is, I think we have to be very careful with that, because a micromet is what's left over after being treated. It doesn't mean that it was originally a micromet. And we certainly know from data out of Memorial and other groups that have gone back and looked at the likelihood of additional macrometastatic disease when your sentinel node contains a micromet, that there is no difference in the likelihood of finding macrometastatic disease, whether the size of your sentinel lymph node metastases was small or big. So there's an equally high likelihood that there is residual disease in that axilla that you may want to know about, either for subsequent systemic or radiation therapy indications, and potentially for local control.
Do you think it make any difference whether you have 2 or 3 other sentinel lymph nodes that are negative? Does it make any difference, the number of sentinel lymph nodes negative at the same time?
Well, one could hypothesize that you've removed the majority of the burden of disease, but we really don't have data to, to support, again, that those patients are going to have equivalent outcomes with de-escalation of therapy. And so again, outside of a clinical trial, I think that we should be performing lymph node dissection with any residual disease after preoperative therapy.
Yeah, if I may, Tari, I totally agree with what you just said. Just to mention that in Italy just started a study about the omission of axillary dissection in patients with micrometastasis in the sentinel node after neoadjuvant chemotherapy. It's not a randomized trial. It's called NeoNode 2, and it's a prospective cohort. So we are going to observe what is going to happen, but I totally agree with you that outside of clinical trials, axillary dissection still is the standard of care at this moment.
Yeah, if I add a comment, it's very important being local policy in radiation oncology departments could be very different depending on the center, since there's several centers that perform post-operative radiation therapy independently. It's enough that you have residual disease, but there are a lot of centers that still irradiate patients only in case of 3, 4 or more lymph nodes. So it's very important to know the burden of disease also in this case and opt for de-escalation also for radiation therapy.
Short comment from my side, if I may. So I think I absolutely agree with what Terry said on Oreste and ECHO. I think many surgeons tend to translate the management of low volume metastasis, micrometastasis, and isolated tumor cells from patients who undergo primary surgery to the neoadjuvant situation. And I think there are 2 very important differences. First, we know from a study from the US, from Mo and collaborated, the rate of non-sentinel lymph node metastasis and micromets after neoadjuvant is 2-fold higher as compared to patients who undergo primary surgery. And the second important reason is that micromets after neoadjuvant are chemoresistant, and we do not know how they behave under radiotherapy. So I think we cannot translate the primary surgery situation to the neoadjuvant situation.
Yeah, so let me just make a comment on a question that from the audience, someone asked, should sentinel lymph node biopsy and targeted axillary dissection be recommended outside of clinical trials? Well, I think that if you have done your own false negative results and your own technique, and you know that it's accurate, then you don't need to do it under a clinical trial. I think that what Thorsten was mentioned is that we really don't know what's the long-term outcome in those patients with clinically positive axilla, and then who has a pathologic negative axilla and have or don't have axillary lymph node dissection. So we don't know the long-term results in all the patients where we are doing the TAD or the sentinel lymph node biopsy. But I think that as far as you know your own data, you can do it, and it doesn't need to be in a clinical trial. Okay, let's move to the next question, because it's also one of these who had several questions in it. So let's move to patients who are clinically negative now. Can axillary radiation therapy replace axillary dissection in selected patients with residual disease in the sentinel nodes? And there are different questions here. If there are 2 or 3 sentinel lymph nodes positives and at least one has a macrometastasis. If there are 1 of 3 sentinel lymph nodes with macrometastasis. If there is 1 of 3 with micrometastasis, and if there is 1 of 3 with isolated tumor cells. So this question is related to clinically negative axilla, and if axillary radiation therapy can replace axillary dissection. So please vote now.
"20 seconds left to vote. "10 more seconds to vote. We are ready to share.
So for the first question, if 2 or 3 sentinel lymph nodes and 1 with macrometastasis, 60% says no to change axillary lymph node dissection to be replaced by axillary radiation therapy. The second one, more or less the same, whether it's 1 of 3 with macrometastasis. In the third one, with micrometastasis, the majority thinks that axillary radiation therapy can replace axillary dissection. And when there is 1 with isolated tumor cells, 81% thinks that radiation therapy can replace axillary lymph node dissection. And as I can tell you, these results are comparing with the consensus at St. Gallen. In the first question, in St. Gallen, the yes was voted by 38%, so a little less. On the second question, half and half, and on the third and fourth question, mostly the same. So maybe our radiation oncologist can tell us if he agrees with this and they are taking over our job in this situation also.
Yeah. I would change the question, since I think that the main question is if there is any indication of treatment in the axilla independently of surgery or radiation therapy. I'm one of the people that really trust that sometimes there's a lot of over-treatment in both sense, surgery and radiation. So we know from the studies, main studies as Amaris and a company, that axillary radiation therapy could replace axillary dissection in case of clinically not positive, clinically negative patients. But I think that more than 1/3 of these patients should not receive neither radiation or axillary dissection. And pivotal trials never test a third arm where no treatment was the option. So maybe I am a little bit provocative, but I think that the real question is who's the right patient for further treatment in the axilla, independently of radiation. It's not something about radiation or surgery. It's something about appropriateness of indication, I think. So just a comment.
Yeah, well, and I also think that we are talking about clinically negative patients to start with. So if you have an isolated tumor cell after surgery, do you want to irradiate that? I mean, maybe if we are, you know, maybe we need to take also into account subtype or molecular subtype of the tumor or other factors. But I agree with you that sometimes we may overtreat. Dr. King?
Yeah, so I think we need to clarify for the audience, just came through the chat. I think some people thought that this question was still related to after neoadjuvant chemotherapy. And I have to admit that I thought we were still talking about after neoadjuvant chemotherapy as well. So,
Yeah,
I think,
so it is
after
neoadjuvant, yes.
Yeah, so obviously really nice data in the upfront surgery setting from AMAROS and multiple other studies demonstrating that, you know, that we probably can de-escalate treatment. And I completely appreciate the comment that we shouldn't always just be trading one for the other. And certainly in the upfront surgery setting, we know that that low volume residual disease does not impact long-term prognosis or outcomes. But after neoadjuvant chemotherapy, you know, as Dr. Kuhn mentioned, that low volume residual disease doesn't mean the same thing after neoadjuvant chemotherapy as it does in the upfront surgery setting. And we've actually published on that it actually, patients with ITCs or micromets in their nodes after neoadjuvant chemotherapy actually have survival outcomes that are in parallel with patients with N1 disease, again, which is in contrast to the upfront surgery population where we know that those patients with low volume disease track with the N0 cohorts. So again, after neoadjuvant chemotherapy, I think even in patients that start out clinically node negative, we have to respect disease that's identified in the axilla as, again, treatment resistant disease. And I think we have to be really careful about extrapolating AMAROS into this population until we have, again, better outcomes data that are follow-up.
Yeah, my comment was in case of upfront surgery and not in case of residual disease. So I perfectly agree with your comment. Yeah.
Yeah, but even though, and you know, just 1 minute because we have more questions going. But you know, I really don't think that the volume of disease in clinically negative axilla after neoadjuvant treatment is the same as in clinically positive axilla. So I'm not sure that ITCs in clinically negative is the same as in clinically positive, because we know from the studies, and there are almost all the studies has very small number of patients with ITCs in clinically negative axilla. So we really don't have much numbers on that to know how many positive axillary nodes are in this setting. So I'm not sure that we can compare ITCs in clinically negative or clinically positive axilla that has the same meaning after neoadjuvant treatment. Well,
I can tell you
also, oops, please go ahead, Terry.
I just say in our limited retrospective review using the NCDB database, whether you started out clinically node negative or clinically node positive, if you had ITCs after preoperative therapy, you had inferior survival outcomes. It was not different between clinical N0 and clinical N1. So I don't necessarily disagree with you, but I'd just say we don't actually have the data that it's okay to leave that disease behind.
Yeah.
And also as a general consideration, the questions were phrased this way, but still we have to evaluate the specific context. So in the neoadjuvant setting, we have the great advantage of evaluating the response. And so in these patients who were node negative at presentation, we can evaluate the response in the breast. So that's a very, very important information in order to decide what to do. But it was like before, at this stage, we do not have enough data to omit axillary dissection in these patients.
Okay, next question. So this is just one question. For biopsy-confirmed clinically positive patients with no or minimal clinical and radiological response to neoadjuvant therapy, is optimal management always axillary lymph node dissection? So please vote now.
You have 20 seconds left.
Well, while the audience is voting, I am taking the opportunity to thank Myriad and Polytech for their support for these webinars. Thank you.
We are ready to share.
Okay, so 85% will say that if you have a clinically positive axilla with no or minimal clinical and radiological response to neoadjuvant treatment, 85% says to do an axillary lymph node dissection. So Dr. King, I'm gonna ask you to comment on this, but also because there is a question saying that if it is routine practice for institutes to perform ultrasound of the axilla, even in clinically node negative. So let's answer first the question of the audience, and then we will go to the other one.
You want me to answer the question about ultrasound first? Sorry, just making sure.
Okay, yeah.
Okay, yes. Yes, so I think that there are different institutional practices. Some groups do routinely perform ultrasound of the axilla, even in clinical N0 patients before considering preoperative therapy, and others do not. We know that in all of the clinical trials, ultrasound was not required. So when we see clinical N0 in NSABP and other trials, we know that that was just by physical examination. Now that we're in this era, though, of de-escalating therapy and which is most forward-thinking, I think, in our HER2 positive population, where our oncologists are really looking to see which patients they can omit standard chemotherapy and just go with a small chemotherapy backbone and anti-HER2 therapy. I think it behooves us as surgeons, again, to make sure that we are really adequately staging the axilla, because it has significant implications on their systemic therapy. So in our HER2 positive population, we actually do routine axillary ultrasounds to identify those women that have potentially multiple positive nodes, even though on clinical exam we can't feel it. But we don't routinely do it across all subtypes. We're just particularly sensitive about that subtype, since we know that, again, that our medical oncologists are going to be really trying to dial back their systemic therapy, and we don't want to miss significant disease.
Okay, so regarding the question, let me just ask all of you, and is a yes or a no the answer, okay? So if this patient has a clinically positive axilla and no or minimal clinical and radiological response, do you perform an FNA or a core biopsy before surgery, or do you just put the patient to axillary lymph node dissection? What do you do, Thorsten, Dr. Kuhn?
Okay, so we will not rely on imaging for assessment of nodal status after neoadjuvant chemotherapy, because we know that the sensitivity, but also the specificity, is very low. We have a sensitivity about 50%, but even for patients who appear positive, the rate of false positive is extremely high. So, and we saw this in the Sentinel trial with very good data on this. So I would not go for primary axillary section for patient with positive nodal status after neoadjuvant. I would go for corneal biopsy.
Dr. King?
So I think if the disease was still clinically very suspicious and palpable, then I would trust my clinical judgment that I would just go straight to lymph node dissection. But I agree, if it's just a question of, is the imaging is not reliable in that setting. And so I do think that we should give patients the benefit of the doubt in that setting.
Dr. Gentilini?
Well, I would do exactly the same as Terry mentioned. So if we are starting with a node positive disease at presentation and we have a very limited or no response, and then the clinical examination is still at least suspicious, then I think that we need to be cautious and go for the most standardized procedure.
Dr. Meatini, what do you do in your
Yes,
practice?
also in our center, it's the same approach. It's the clinical palpable disease, probably axillary dissection. In case of only imaging, then probably corneal biopsy.
Good. See, we are all agreeing this one. Okay, let's move to the next one. And this is about radiation therapy. So for women who with estrogen receptor positive HER2 negative stage 1 or 2 breast cancer, the preferred radiation treatment dose and schedule after breast conservative surgery with negative margins, irrespective of age, is standard hypofractionated whole breast irradiation, partial breast irradiation, the ultra short whole breast radiation therapy, or any of the above are the preferred options. So please vote now. Yeah, well, the question, you know, yeah, it's so, yeah. This is not personalized medicine at all.
We are ready to share.
Okay, so 66% vote for the hypofractionated, 9% the partial, the ultra short 3%, and any of the above 22%. Well, let me tell you that in St. Gallen, the 80% decided on hypofractionated, none of them for partial, 8% with the ultra short, and 20% of any of the above. So I can tell you that, you know, you could be at the consensus because most of the questions are almost the same. So, Dr. Meatini, some comments on this, please.
Yeah, it's depending how the question is made, because I perfectly agree with this reply. This is related only to the adding of the irrespective of age. So in this case, the audience have to follow guidelines, and it's a moderate hypofractionation. Why 16 fractions? I don't know, probably 15 it's okay, 14, 15 is now a standard of care, but also 16. So moderate hypofractionation is the new standard of care and should be the new standard of care. However, I think that more comments are needed, since if you remove irrespective of age, in this case, you have a T1 estrogen receptor positive to negative, low risk patients. So moderate hypofractionation, ultra hypofractionation with 26 and 5 fractions following the fast forward trial, even if it's a 6 years follow-up phase 3 trial. So with very robust data. And why not partial breast irradiation in case there is not a non-lobular breast cancer? So it's a multifactorial decision. With moderate hypofractionation, it's always okay, but it's 3 weeks of treatment. I think in this case, there are several options that leads to 5 fractions as maximum. It's 1 week of treatment, whole breast or partial breast, depending on other characteristics.
So are you using ultra short?
We start using the ultra hypofractionation in since it's a 6 years median follow-up trials. We decide to start with a prospective cohort trial, a registry trial, in order to test the acute, early, late, and safety of treatment. But really, the fast forward trial is if not the present, the near future of whole breast irradiation for our patient.
Good. So, good. Let's move to the next question. And we are now, oh, sorry, any comments?
Now, I have one question to Ivo, if I may. So Ivo, because you've worked a lot of de-escalation of radiotherapy with the partial breast irradiation and so on and so on. So what is the distribution in your institution between whole breast irradiation with hypofractionation or modified hypofractionation, with partial breast, with ultra hypofractionation, and omission of radiation? Can you give us an idea of the distribution?
Yeah, thank you very much also for this nice question. Usually, currently, we use 70% of moderate hypofractionation in our institution, 14-15, when a tumor bed boost is required. For very low risk patients, we use 26 and 5 fractions in this prospective registry cohort. When the features are allowed for partial breast irradiation, so non-lobular with adequate margins, we use partial breast irradiation. We never omit radiation therapy. If I want to omit radiation therapy, I enroll patients in the Europa trial, that is a multi-center studies that were the University of Florence is promoter, that randomized very low risk patients over 70 years old to receive endocrine therapy or partial breast irradiation, just to test local relapse rate and health-related quality of life of patients. This is the new frontier of de-escalation of treatment, aiming to other primary endpoints, just rather local relapse rate.
Icaro, if I may ask one more question. So are you using ultra short hypofractionation irrespective of age, or are you using this just in elderly patients?
No, not elderly, because elderly now is 70 years age. We are using fast forward following the features of the phase 3 trials. So age more than 50 years old and T1 or T2 and 0 patients. Usually starting now, we prefer there's not an indication to a tumor bed boost, since there's something to discuss about late toxicity with ultra hypofractionation.
Thank you.
Okay.
You're welcome.
Okay, let's move to the next question. And now we are going to talk about not neoadjuvant endocrine therapy, but it's question related to how to triage patients. So can genomic assays on core biopsies be used to select patients with ER-positive, HER2-negative breast cancer for neoadjuvant endocrine versus chemotherapy? So vote now.
You have 20 seconds left to vote.
I'm gonna give you the answers on St. Gallen before we get these ones. So they both, oh, well, I'm going to wait until they finalize the voting. Okay. Okay, 67% say yes and 33% say no. St. Gallen answers were 73% say yes, so more or less the same. So Dr. King, any comments on this?
Yes, well, here in Boston, we absolutely do use the core biopsy for genomic assays to help make the decisions for preoperative therapy in that ER-positive, HER2-negative group. I think it's going to become increasingly important because we are now learning from data from TAILORx and RxPonder that the majority of women with ER-positive, HER2-negative breast cancers actually don't benefit from adjuvant chemotherapy. And so if somebody's not going to benefit from adjuvant chemotherapy, then we certainly shouldn't be using neoadjuvant chemotherapy just to shrink a tumor, particularly when we have, again, prospective clinical trial data showing that neoadjuvant endocrine therapy is just as good at achieving breast conservation as neoadjuvant chemotherapy is. So I do think that we need to have some tools to help in decision-making in the preoperative setting for these women. And I do think that the data showing that core biopsies are concordant with surgical specimens. There's large data sets on that from particularly from Genomic Health. And it's just as good as when we used to argue about, well, can you trust ER on the core biopsy? Is it the same as surgery? Or can you trust HER2 on the core biopsy? Is it the same as surgery? The data is really no different. So I do think we can trust it on the core biopsy.
Yes,
well,
yes. Sorry.
Can I may say a comment, because Terry, let me tell you that I am envious of your situation, in the sense that at least in our country, we have a major problem, which is reimbursement, because as of today in Italy, we have reimbursement only in Lombardia and in Tuscany for genomic tests after surgery. So it's not conceivable, at least at this time, to use it in the, let's say, at presentation in order to decide what to do. But I hope that this will be available soon in our country as well.
Yeah,
Yes,
I can tell you that. Yeah, sorry, go ahead.
I was just going to say, absolutely. I understand that that access and resources are a problem in many places, and when we started doing this, we also would get pushback from the insurance companies about not paying for it. But thankfully, it's getting a little bit easier here, and hopefully it will become more widely available.
Yeah, we are doing that too, and we are also using a MammaPrint because you know, we have these patients with luminal B tumors that you really don't know what's the benefit from them, and I can tell you that even we don't have reimbursement for that either in some places. In most of the places we have in Spain, I mean, patients are just willing to know because, you know, even though some of the ER positive can be ER negative by blueprint. So you know, at the end, you can triage whether they need neoadjuvant endocrine or chemotherapy much better. And the response, you can even get better responses. Okay, we don't have much time, so I'm not gonna let you comment on this one. Let's move to the next one. Sorry, well, you know, you tell me we need to be on time.
I told you to be on time.
Yes.
Must accept.
Okay, so next question is, should results from commercially available genomic signatures, whether MammaPrint, intrinsic subtype, recurrence score, be used to inform decision on omission of radiation therapy in breast conservative surgery in invasive breast cancer? So both now. The other one was core biopsy to triage patients for neoadjuvant chemotherapy or endocrine therapy, and this one is to use to inform on the decision to omit radiation therapy or not after breast conservative surgery.
10 more seconds to vote. We are ready to share.
Okay, so 77% says no, and St. Gallen 83%, so more or less the same. Dr. Beattini, can we omit radiation therapy related on genomic assays?
Not now. I think that genetic tests should be assessed in the context of clinical trials in order to focus also on radiation rather than exclusively systemic treatment omission or de-escalation. Actually, several trials are currently investigating de-escalation approaches according to the strategy of precision medicine, omitting radiation therapy. Europa is one of these, but also the expert trial, the natural trial, the precision trial. There are phase 3 trial, but also phase 2 cohort trial, Prime Time, IDEA, Lumina, and in at least in the expert precision and maybe IDEA, if I were remember, that's the test of genomic assay in this context. So please go on with clinical research.
Okay. Yeah, I think we all agree in this, that we need more data to omit the radiation therapy in these patients. Yeah. Okay, let's move to the next question. Breast reconstruction. So for women likely to warrant post-mastectomy radiation therapy, what is the optimal type and timing for reconstruction? No reconstruction, delayed reconstruction after radiation therapy, immediate implant-based reconstruction in 1 or 2 stages, immediate autologous reconstruction, or delayed immediate reconstruction. That means putting an expander, irradiating, and then doing an autologous tissue reconstruction. So you can vote now.
You have 20 seconds left. Ten more seconds to vote.
Okay, so no reconstruction, 0%. Well, I'm glad that people think that patients need to have the option to get reconstructed. Delay reconstruction, 30%, 13%, 20% in St. Gallen, Immediate implant-based reconstruction with 1 or 2 stages, 36%, 22% in St. Gallen. Immediate autologous, 15%, 25% in St. Gallen, and delayed immediate, 37%, and more or less the same in St. Gallen. So before starting this, Dr. King, what do you do in your practice?
So this is a very complicated subject, because if you believe the patient-reported outcome data generated from the large multi-center MROC study, that study suggests that actually it's better to do autologous tissue, and that radiating autologous tissue results in better long-term outcomes than radiating implants. But when you look at what happens at individual institutions, there are very few plastic surgeons that are willing to do an autologous tissue if they know there's a high probability of PMRT. So at our institution, we do the placement of the tissue expander, determine if the patient needs PMRT or not, treat with the tissue expander in place, and then the patient then still maintains the option at the time of the second stage to convert to autologous tissue or to continue with an implant. And I again, it's hard when you look at the data and you listen to the talks, but then when you see what people do at home, it's not always the same.
Dr. Kuhn?
Well, I agree absolutely entirely with the voting from St. Gallen, but also of the attendees of this conference, because I think it's a very, very individual decision. So I agree, we also rarely use autologous reconstruction as primary reconstruction. One of the reasons is that patients who undergo radiation therapy often also have chemotherapy, and we're a little bit afraid of complications from autologous reconstructions, which may delay systemic treatment. But for the other options, I think it's very, very individual, and I think the individual patient counseling is very important in this issue.
Dr. Gentilini, what do you do in your practice?
Well, as it was previously mentioned, it's a very, very individual decision. Obviously, you have to evaluate age, you have to evaluate the size of the breast, the shape of the breast, some personal features. What we usually do is an implant-based reconstruction. So this is what we usually do. Actually, we started recently with the prepectoral reconstruction and using the polyurethane, which is associated with a much lower rate of capsular contracture, and the initial experience is very, very encouraging. So that's something that we might think of in the future.
And then the reason for our problems, Dr. Meatini.
Yeah, I think that, thank you, no pressure. No, I think that it's nice, since it's a really debated question. I think so. I agree with all of you. Autologous tissue-based techniques compared to implant-based techniques would be preferable in the setting of post-mastectomy radiotherapy, both planned immediately or after mastectomy or in a delayed fashion. Anyway, it's real life. There's data and real life. A total autologous-based scenario would be difficult to be feasible as per patient expectations, characteristics of the patients, of the treatment, technical logistic reasons due to long duration operation, consequent impact on operative room, schedule priority. This is why basically immediate implant-based techniques remains the most frequent reconstructive option offered to women undergoing post-mastectomy radiation therapy. In the setting of the immediate breast reconstruction, the use of one stage approach is still also debated. There's no definitive evidence exists, is available about the outcome of irradiating the expander or the permanent implant, as well as the potential positive impact of a prepectoral approach. From a specific radiation therapy point of view, I would like to be reassuring, since target volume definition, delineation, and the presence of the immediate breast reconstruction is tailored, is much more tailored to avoid the implant when it's possible, depending on the surgical approach. Now is it technically possible, crucial, reliable, thanks to techniques as intensity modulated radiation therapy, volumetric radiation therapy. although the evidence is still low, please use the Astro guidelines when you contour our patients, because the guidelines exist and should be strictly followed. I think, and this is my main comment, is that clear communication and cooperation between surgeons and radiation oncologists is crucial, both in the setting of breast reconstruction following mastectomy, even after breast conserving surgery. And the choice of the reconstructive approach must be individualized with a patient-specific approach. That's the main point.
Good, thank you. Yeah, we also use expander, and then because we think that, you know, at the end the patient has another option to decide depending on the results of the reconstruction after the radiation therapy. So we are moving to the last question, but let me ask Dr. King you a question before. There is a question here asking, Ki-67 after 2 weeks of neoadjuvant endocrine therapy can partially substitute a genomic assay if you can't use a genomic assay?
Thank you for that comment. Yes, I know there's, you know, obviously Ki-67 has been a matter of debate around the world for many, many years now. And I think that, you know, Giuseppe's group in Italy has much more experience and confidence in it than many of us do in the US as far as reproducibility. And so I think that when that score is low, that's reassuring that you are treating an endocrine sensitive tumor. But we just saw the results from the alternate trial at San Antonio, I think, you know, a few months ago, that if you have a high Ki-67 after 2 weeks or 4 weeks of treatment with neoadjuvant endocrine therapy, that switching to chemotherapy doesn't necessarily increase your rates of achieving a PCR. So it doesn't necessarily tell you that the patient's going to be sensitive to chemotherapy if it doesn't go down. But certainly if the Ki-67 goes down, then you can be more confident that they are endocrine sensitive.
Okay, thank you. Well, let's move to the last question. Above which age can any axillary surgery be avoided in case of N0? Older than 70, older than 80, older than 90, or never? So you can vote now.
Twenty seconds left. 10 more seconds. You're ready to share results.
Okay, so 23% said that above 70 years, you can avoid any axillary surgery in clinically negative axilla. Above 80, 50%, above 90, 13%, and never around 20%. So this is more or less the same answers as St. Gallen. And maybe Dr. Gentilini, can you tell us something? Because
why are you asking me?
Because you have data that we don't know, and we want to hear something about the sound trial.
Well, what I can tell you is that hopefully we're going to release the data of the sound trial in the second semester of this year. So until then, I keep my mouth shut. No, I can tell you what we are doing in the everyday life. So basically, we do it sentinel node because it's still the standard of care, unless the patient is too fragile, and so we keep the surgical procedure as minimal as possible. But if the patient is fit, then we offer to the patient the standard of care.
Okay, Dr. King?
So in the clinical N0 ER positive HER2 negative breast cancer patient, where the decision for systemic therapy is hormonal therapy, irregardless of the nodal status, then we do not routinely do sentinel node in women over the age of 70. And I use the word routine because there's exceptions, but certainly in that population where we know the systemic therapy decision will not be altered, we don't feel that the information is needed. And again, we know from data from CLGB trial, which was not a trial of omitting nodal evaluation, but was a trial of omitting radiation in women over the age of 70 with early stage ER-positive, HER2-negative breast cancer. We know that 2/3 of women in that clinical trial had no axillary evaluation whatsoever, and their rates of axillary failure at 10 and 12 years out are quite acceptable and quite low. So I think there are groups, and I think that you need to use a combination of age and molecular subtype to decide when you feel it's okay to omit those procedures.
Do you do axillary ultrasound on those patients?
If they meet CLGB criteria, no, we do not.
Okay. Any other comments on this?
In Germany, we would omit sentinel lymph node biopsy in case that the information of the nodal status does not impact adjuvant treatment, and the patient has a life expectancy of 10 years. So we would not choose a specific cutoff, but for us, the cutoff is life expectancy of 10 years.
Yeah, we do that too. I think that if we are not changing anything in treatment in the patient, we don't do it in those patients. Okay, so we are on time.
Great job.
That's for my part, and I will let Dr. Kuhn to just make the conclusions and all that. But thank you for the questions. I'm sorry that we didn't have much time to answer all the questions. We will try to answer some of them when we are finishing the webinar. But thank you for the participants, and Thorsten, I let you close the webinar.
Okay, thank you very much, Isabel. First of all, I want to thank our guests, Terry King and Aiko Miatini. It was really fantastic to discuss with you. It was really perfect to have this interdisciplinary discussion on the St. Gallen results. But also want to thank all participants. I think we had more than 140 participants, and so I saw that very few people left, so we are almost the same number of people sharing this webinar. Certainly a lot of thanks to Isabel, who was a perfect moderator, and she kept in time. We had a discussion on this yesterday, but Isabel, you were perfect. And therefore, thank you all. I think it was a very good experience. I thank you in the name of EUBreast, also from the view of Oreste Gentilini, who is co-chair of EUBreast. I want to invite you to participate in our initiative to perform joint clinical trials in Europe or worldwide. Please visit our website, EUBreast.com. We have 2 ongoing trials, the EUBreast 1 trial and the Axana study that was mentioned, and everybody who is interested may participate in these trials. So I wish you a very, very nice evening, and thank you again for participating in this webinar. Thank you.
Thank you.
Okay.
Thank you very much.
Bye-bye.
Bye.
Thank you.